I know we are a small group at the moment. We'll give people a few more minutes to gather, and then we will start shortly. So bear with us, and thank you for being here. Good afternoon, everyone. Welcome to Women's Wellbeing Lecture Series, brought to you by GW Resiliency and Well-being Center and made possible with the financial support from Dr. Rosemary Bowes, PhD Endowment Fund that supports and promotes women's well-being and resiliency. Today, we are going to dive into a very important topic on discrepancies and disparities in healthcare as it relates to women. And it will be led by our amazing guest speaker, Dr. Esther Choo, MD, MPH. Dr. Choo is an emergency physician and health policy researcher in Portland, Oregon. She speaks and advises organizations on improving equity in the workplace in the provision of healthcare, and has published in New England Journal of Medicine, Harvard Business Review, Washington Post, NBC Think, and USA Today on these topics. She is a founding member of Equity Quotient, an equity consulting group, and a health columnist for MSNBC. So with that, I'm gonna give it to Dr. Choo, and we look forward to your lecture.
Thank you. Can you hear me okay? Okay, my sound seemed to be going in and out, so please just let me know if anything changes. And I also, I cannot see the chat or the screens while I'm talking, but so please just unmute and speak up if you wanted to ask a question or clarity. I think it's a small enough group that we have time and the luxury of just stopping to chat here and there. So I wanted to just mention my conflicts of interest, which were already mentioned. I'm co-founder of a consulting company called Equity Quotient, and I won't mention it again in this conversation. There's a lot to cover. I tend to be a little ambitious with time, so I may move through some slides quickly just so that we can get to the end and I can hear from people here. But basically, we'll talk about definitions of health equity and DE&I. We'll discuss some inequities that show up in the receipt of healthcare around especially women, but also racial minoritized populations. And then we'll transition to talking about workplace inequities, and then end with a conversation of potential solutions that I think will just touch on a few things that are kind of front of mind for me, but also would love to hear from those of you attending as well. The talk will focus mostly on areas of sexism or gender disparities, but I'll also talk about some racial and ethnic disparities. I will say data tends to be very gender binary, and this is a very data-driven talk. So if you feel that it is too gender binary, I often kind of default to the way that data is presented, but I acknowledge that that is a weakness in the data and in the conversation. And then I will say also intersectional impact of clinical and workforce experiences are so important, but under-recognized and studied, and that is also a weakness of this conversation. I will drop a lot of references. I think most of them are here on this Google Docs, which I believe I have shared. So you can either type in that link or you can just hold your phone up to the QR code. And if you scan, it should take you to a Google Doc. And if for any reason you're shut out, I can send it around afterwards, and I will also put the same slide up at the end. And I believe most of the references that I talk about will be there, so you don't have to write them down if you're interested. So just starting with a few basic definitions, because I think there's a lot of language that floats around when we talk about words like health equity and DE&I. The definition I use is the absence of systematic differences in health between more and less advantaged social groups. And I think just the definition that I put in my pocket that I think about when I walk into every shift is that every patient walks in the door to our healthcare settings and feels that they were respected and cared for to the best of our ability. And then we're able to back up that feeling and find that it is statistically true when we look at important health outcomes. So that to me is kind of like my working definition of health equity. Now, when we talk about diversity, equity, inclusion, we're generally talking about our workplaces. Diversity simply refers to valuing the similarities and differences that define us as human beings. Equity is different from equality. It's this principle of distributive justice. So it recognizes that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. And then inclusion is a climate that we create to allow organizations and individuals to benefit from a diversity of ideas, knowledge, and experience. So with those working definitions, let's start from the healthcare inequities that affect women. Again, I'll talk mostly about women, but we will touch on other socially disadvantaged groups. So this is a huge topic, could easily use an hour or two in itself, but I'll just talk about mostly the exemplar of cardiac disease, simply because cardiology, for whatever reason, has really taken an interest in the way that sex and gender affect everything about cardiovascular disease, its manifestations, its presentations, the way that it is treated, and its outcomes. So this remains the leading cause of death for women globally, about 35% of deaths in women in 2019. And yet women still experience this kind of clinical gaslighting. So especially younger women who have coronary artery disease and present with myocardial infarction, with signs of myocardial infarction, are more likely compared to men to be told that their early symptoms are not cardiac. Women who present with ST elevation MI are still less likely to receive angiography or revascularization. They receive revascularization later in the course of their disease. They have poor outcomes, including a more persistent angina after revascularization, and a twofold higher adjusted rate of death and recurrent MI compared to men. And when it comes to prescribing along standard clinical guidelines, the adherence to those guidelines is poor among women who have had STEMI compared to men. And so if you look at data, this is older data, so this ends at 2006, but you can see that when we started in the really like with these huge clinical trials with excellent acronyms, like in the 1970s, men had higher cardiovascular mortality than women. So men are the gray and women are the black bar. And then that changed over time, where men had these significant gains in improved cardiac mortality and women lagged. So what do you think was happening in this time? Any guesses? You can go off mic or you can drop in the chat.
Men were getting treated.
Yeah, we were getting much more aggressive about trying to figure out this puzzle for men. So what happened in this period was that there were a ton of clinical and observational trials for MI for men, everything from modifiable risk factors to acute interventions. But during the time period captured here, 85% of trial participants for cardiovascular disease research was men. We were simply not enrolling women or really interested in how disease played out in women. And you can see this, this is from the same paper. The first bar for all these different conditions, the first bar is the percentage of women enrolled in RCTs devoted to that topic. The white bar is the percentage of women among the population with the disease. And then the last one is the deaths attributable to that disease among women. And so you can see we were enrolling women in RCTs at a much lower rate than the burden of disease among women. And, you know, the really concerning thing is, you know, I always sort of talk about this exemplar of cardiac disease, but if you look across diseases, there's evidence that we're probably doing the same thing en masse to women across conditions. So this is a study of a sample of NIH funding dollars. And this author, I thought it was interesting, it was actually a male author who looked at this, but this author took a bunch of male dominant diseases, meaning that the disease affected men, at least 60% or more of the people affected by the disease were men. If you looked at male dominant disease, they looked at what is the actual funding devoted to that disease compared to what would be commensurate to the disease burden. And if you there's a lot of numbers, so I just put a bar around the most recent year they present. So a 1-to-1 ratio would be kind of a good balance, right? It would be kind of, well, we fund according to the disease burden. So if you look at male dominant diseases, we tend to fund at or above what is the disease burden. The ratio generally tends to be 1 or above. And then just take a look down those actual 2019 dollars and burn that into your brain for a second. So you can get a general sense of the scale of dollars that we devote in millions to these male dominant conditions. And then I'll show you, these are female dominant diseases. They occur disproportionately among women, or in the case of something like endometriosis, exclusively among women. And then look at that ratio, the actual dollars versus the commensurate dollars, what would be appropriate to disease burden. Just a completely different ratio you're seeing here. And then again, if you had that, look at the last column and look at the scale of the dollars devoted to those disease. And the conclusion of this study was, we find that in nearly 3/4 of the cases where disease affects primarily one gender, the funding pattern reflects males, in that either the disease affects more women and is underfunded with respect to burden, or the disease affects more men and is overfunded. And then, of course, if you look at women's specific diseases, we actually see this trend in outcomes that really seems to match the kind of research and innovation attention that we give diseases. So this is data from 2023, but a brand new study that was put out by the National Center for Health Statistics earlier this week. And you can see, despite all the discussion and concern about how the US is doing poorly in terms of maternal mortality, it is getting worse, substantially worse year to year over the past 3 years. And you can see that this is not uniform across the population, but different based on race and ethnicity, with worst outcomes among Black women. And I will just say, to again underscore this intersectional point, that first of all, there are inequities upon inequities. So when we look at women's health issues, we need further stratification to understand how subpopulations of women based on race, ethnicity, sexual orientation, poverty, and so on, tend to exacerbate the inequities we can see just by this really blunt instrument of looking across genders. And then I also wanted to make the point with this slide that many of the inequalities that play out in healthcare are built in. They are structural and systemic. And one really good example of this is kind of the calculators and the scores that are so popular in healthcare and often are literally built in like to our EHR and reinforced. So if we look at, VBAC, vaginal birth after C-section, there's a score that subtracts from the estimated success rate for any person who's identified as Black or Hispanic and lowers the estimate that can dissuade clinicians from even offering trials of labor to people of color. If you look at something like osteoporosis, which is female dominant, there are racial and ethnic disparities built into that in terms of scores that lead to early initiation of osteoporosis therapy, and then UTI calculators for children in terms of fever and sepsis are also biased by race and ethnicity. All of these based on pretty poor data, and yet systematically bias the care that we give. And so we look at these downstream inequities and we wonder, where are they coming from? And of course, there are many, many driving factors, many of them on a societal level, but certainly we have a lot of baked in elements in healthcare that we need to tackle. And so we see things like this. This is data from California, but certainly represents what's happening nationally over the course of the sort of looking at pre-pandemic and then current pandemic era data. We just had a huge drop in life expectancy, and the gap between the richest and the poorest percentiles has increased dramatically. These are things that will have generational effects and will take many, many years to correct, if ever. And I just want to make the point that it's not just that we, that we're doing okay, but if you look, there's some inequities. Inequities are really the driving force when we look at how the US performs globally in terms of the health of its nation. So this is a report from the Commonwealth Fund, where they looked at a bunch of different ratings of how the US compared to other peer high income countries. And the conclusion was that we rank last overall in most categories, despite spending far more of its gross domestic product on healthcare. The US ranks last on access to care, administrative efficiency, equity, and healthcare outcomes. And this is our ranking in terms of health equity. And you can see we really pull away from the pack in terms of how very low we perform in key measures of health equity across our population. So health equity is a defining thing for us. So what does all this have to do with diversity, equity, inclusion? I mean, I think the connection seems intuitive, but I used to think of them in very different buckets, like health equity is over here, and then diversity, equity, and inclusion is over here. And it wasn't always clear to me that those two things were related, but I've changed my mind. And a lot of it is that there's been some really interesting literature about what happens when you bring in a more diverse worker population. So this is a study out of Florida, a large Medicaid population that looked at what happened when female patients came in after having, while they were having a heart attack. And so, if you think about it, it's kind of randomized, a quasi-experimental study, because when you come in for an MI, there's a doctor on and you didn't pick that doctor and they didn't pick you. It just happens to be either a male or a female doctor. And so they they found in the study that female patients treated by male physicians were the least likely to survive an episode of care. And patients, male or female, treated by female patients were in this unmatched sample were more likely to survive regardless of patient gender. And then they looked at something I think that was super interesting. They looked at what happens to survival in EDs if you just looked at the overall proportion of female physicians in that department. So forget about who you were randomized to, but what is the quality of care if you presented to a department that had better proportion, that higher proportion of female docs overall? And they found that female patients experienced better outcomes in EDs that had a higher percentage of female physicians. And that relationship was particularly true for patients treated by male physicians. In other words, men who were working in settings where there was a higher proportion of women had much better improvement compared to men who worked in all male settings. And I think I love this study because it really speaks to something other than just like, did women physicians do well and did male physicians do well, and let's compare them, and who treats women physicians better. But it really talks about how when we're in settings that are diverse, the quality of the care, really the quality of everything that we do is elevated. And I think that's really the point about DEI. There's been numerous studies. I won't spend a lot of time, but really these are famous, extremely talked about studies that looked at these huge Medicare populations and what happens again with this quasi experimental situation where you land in the hospital and oops, you have a male or a female physician or someone tagged as male or female. And what we've seen now across numerous studies is that hard outcomes, not like, did you feel listened to? Did you feel like somebody loved you? It's like, did you have a cardiac event or did you die before you left the hospital? Hard endpoint outcomes are actually better if you're treated by female physicians. Very similar data among surgical outcomes as well if you're treated by a female surgeon. And then I'll just say we're also observing the same thing with racial concordance. This was a large recent study looking at what happens to newborn mortality if the race of the newborn is concordant with the race of the treating physician. And so, and then, this really interesting study from Oakland, this is in the economics literature. This is a study that took young men who were presenting to barbershops, actually not presenting for care. They were recruited to a primary care facility where they were randomized to either a racially concordant doctor, a Black doctor, or a white doctor. And they found that if they were randomized to a racially concordant doctor, they were more likely to receive blood pressure and BMI measurement, agree to diabetes and cholesterol screening, and accept the flu shot, just kind of basic preventive care. And they extrapolated out and found that if we had more racially concordant care, the estimated reduction in cardiovascular mortality would be 16 deaths per 100,000 per year, which would lead to a 19% reduction in this really tenacious Black-white male gap in cardiovascular mortality. So all to say that while the goal isn't, to be, there's no time when we'll be able to just like be super matchy-matchy, I don't think, but I think it just speaks to the real hard endpoint, meaningful patient-oriented difference in outcomes when we move forward with diversity in our clinical settings. And so what I would say is my thesis is that health equity work cannot occur without a foundation of DEI. Is that fair?
Absolutely. That was fabulous.
All right, I'll move forward. So let's talk about some of the workforce inequities, because if we want to sustain this great, diverse workforce that feels equitable and is truly inclusive, that is what I think will draw and sustain the workforce that will best serve our populations. But do we have that workforce? And I would argue that we have a long way to go in almost every measure of equity or inequity that you could talk about. So representation, specialty and role segregation, wages, leadership, promotion, day-to-day treatment. And I won't spend a lot of time on all these, but again, kind of a survey so that we can all be on the same page with respect to where we are now. So first of all, I'll say there's this very real concept of workforce segregation and also undervaluing of work that is done by women. And this is something that we can see over time as specialties become more dominated by women in healthcare. We the reimbursement rates are low, and the reimbursement is the compensation is low, and you can just chart this out, based on percentage of female share on the x-axis, and then on the y-axis the average salaries. And this is certainly true across all roles in healthcare. If you look at the lowest wage jobs in healthcare, those are dominated by women. 80%, I believe 80 to 85% of the low wage health service roles are occupied by women. And these are, of course, the roles that pay the least. So I spend a lot of time thinking about physician salary inequities, but the bigger picture, I think, is more concerning and really, really calls for a reevaluation of how we value and compensate people. Of course, equal pay days, there's this whole thing about equal pay day, which is how far into the year women need to work to make the same as men earned by the end of the prior year. But there are many equal pay days, so for women, it shifts every year, but for women, it's usually March. If you add in mothers, and we'll talk more about that later, but if you add in that you're a mother, you have to work until June to catch up to men from the previous year. If you're a Black woman, it takes till August. If you're Native American, it takes till September. And if you're a Latina woman, you have to work almost the whole next year to catch up to what men earned the previous year. Is it getting better? The big picture is yes. However, when we look at projections of when the pay gap is going to close, it really took a downturn during the pandemic. So, it was kind of slow going, particularly for women of color. But now, if you look across groups, the pay gap is now extended further into the future. And if you look at this blue line, which is Black women, it's actually projected to close never in the foreseeable future. So a lot of reversal to do there too. This is something that I think is really worth looking at across all the roles in healthcare. So this is a widget that's put out by the US Bureau of Labor Statistics. And what you can do is you put in the occupation, and then you can select this. If you look at the bottom drop-down menu, you select what are women's earnings as a percentage of men's. And I went through and just looked at a bunch of different roles, people I work with every single day. And it is a little discouraging how low it gets in certain healthcare roles. I've also looked at a bunch of non-healthcare roles, and it's fascinating. So just something worth spending time with. The link is in the references. And this is persistent. Some people are like, well, if we get more women in, these kind of things will resolve. And I've always been skeptical about that, because if you look at any subspecialty of medicine dominated by women, like OB-GYN, or if you look at nurses, men still make more money consistently over time in those jobs as well. So here's data. This is somewhat dated census data from nursing, and you can see men consistently make more, and it doesn't even seem to be a closing gap. If anything, it's getting better, getting bigger. This is data from pandemic era data, just suggesting that again, that the problem is getting worse. This is actually not adjusted, it's just raw data, but look at the RN median primary salary compared to the male median primary salary, and just extrapolating from other non-adjusted data, it's likely to be getting worse. Leadership is another area where we see obvious, huge, see it from space kind of inequities. So women actually, I think, drive healthcare. We're 80% of consumers making buying and usage decisions. We are the primary caregivers over the lifespan. We have 84% of bachelor's degrees in the health professions. We're 65% of the overall healthcare workforce, but we're only 30% of C-suite teams, and we're only 13% of CEOs. And if you look at some of these, this is just US Medical School department chairs by chair type and sex, and it is getting better over time, but very slowly so. And I think may take a downturn again due to pandemic effects. And so that's why you can always get these comical headlines like "Men named Michael outnumber female CEOs" presenting it at the JP Morgan 18 Health Conference. And the funny thing is, Michael isn't even the most common CEO name, it's John. But you can go to Michael, and there's even more Michaels than women, and those kind of statistics are so easy to find. So why do we have these inequities in the workforce? And I think we can easily see the devaluation of women, and there are so many studies like this. So this is a really famous one out of Yale that I love to talk about. This was a nationwide sample of biology, chemistry, and physics professors. I think this paper is from 2012. And so they sent out at random to 127 professors. And the professors themselves, by the way, were male and female. But they asked them to rate an applicant for a laboratory manager, and they sent them a CV of one of two candidates, and who they received was randomized. And the candidates were designed to be identical in every single way, except for gender. And this is what they found when they rated the lab manager for competence, for hireability, and for whether they would offer mentorship to this candidate. They were the male student was rated significantly higher on all of these things. And then they asked them to estimate the salary they would offer to this person. And the male student got a higher salary, even though they were the same person, literally. And you see this play out. You know, if you look at starting salaries, these are starting salaries of male and female physicians. Okay, starting salaries straight out of residency. Everybody has pretty much just finished residency. You don't even finish residency with a grade. So it's not even like there's an A resident who graduated or a B resident who graduated. You just finished and you're ready to work. And then over time, get higher starting salaries. And again, this is not changing much over time, no matter what you adjust for. A specialty, you know, work-life preferences, part-time, you know, these kind of studies now adjust for so many things, and we're not seeing that this is correcting over time. And I think the concerning thing about that is when it is from the outset, it's like, I haven't even seen you yet. I just have your CV and I'm already starting to value you differently based on your gender. And we see those effects actually by race and ethnicity as well. But when you start at the very beginning, making these maybe small differences in valuation, the problem is that those are compounded over time, whether we're talking about pay, assessment for leadership roles, you know, anything that we, you know, nomination for awards, opportunities that are given, all these things tend to compound over time. And I think when we extrapolate out to the end of one's career, we really understand why we see those leadership discrepancies that we do, because it starts early and everything builds upon itself. There's another element to this. And just to point it out, I want to give you a hypothetical scenario. So I'm going to give you a 41-year-old physician, and this physician is 10 years out from residency. They initially went into work and had 2 years that were full-time, productive, and very high quality work in an academic setting, even won actually a teaching award. And then had several young children in quick succession. So took time out and actually just worked per diem in the community about 6 years. And then the kids went to school and they decided they wanted to explore a semi-academic job, and they're open to leadership roles. Okay. So this physician applied for a job, and these were the available positions. There was the option of part-time clinical work with potential transition to full-time at a later date once they kind of prove themselves in an academic setting. They could go straight into full-time in a clinical role. There was actually a leadership position, a section chief role that's open for someone who's, you know, capable and interested, or this candidate could be passed on. And I'm actually very curious as to what people think would happen to this physician, should happen to this physician. And you can think of this in any way that you want. You can think, what is likely to happen in an academic setting? What would you offer if you were the chair and this candidate came to you and you have many other candidates on your desk?
Well, I have to say, I don't typically hire a lot of clinical roles. This is out of my scope, but I'm going to put myself out there. And I could see where there would be hesitation to just jump right into a full-time clinical role. And so perhaps option A is sort of the happy medium. You give them the opportunity to shine so they can do it, and then already set the road for them to have that full-time position.
Hello?
Totally. Hello? Anybody else?
I would agree. I mean, in an ideal case, you want to give an opportunity to start with a part-time and then transition to a full-time once they're comfortable.
Yeah.
Is this for the people that's struggling with alcohol and methamphetamine?
No, I think you are in the wrong space.
You're in the wrong space, but you're welcome to stay.
No, it
We're
looks
talking
like
about
I'm in the right
we're
space.
talking about women's careers in healthcare and healthcare inequities.
That sounds like a big lie.
I can also talk about methamphetamines, though. So I will admit that I agree with you. I actually think, I don't know if it would be my decision, or I think often what happens is that it's people take time out for their families and they transition back. So, however, in this case, this was my husband, and this is what he was offered with this background. And I will tell you, I've talked to a lot of women about this exact issue, and this has never in the history of jobs or women ever happened to a woman. And so what is going on here? And after this happened, we were a little astonished, and my husband and I actually found this literature. There's something called the motherhood penalty, and this is studied. So this study looked at a bunch of participants who read a description of a company that was hiring for a mid-level marketing position. And they looked at application materials for 2 hypothetical applicants for the position. And like the previous study, they were designed to be similar in all aspects except for parental status. And so this study actually wasn't looking at men versus women. It was looking at among women, what happens if you're a parent or a non-parent, and among men, what happens if you're a parent versus a non-parent. And this is all the female applicants. And so if the female applicant on their CV indicated they were a parent, and it was really subtle, just at the bottom under activities, it said that you were the member of a PTA, a Parent and Teacher Association. But if that little clue were on the CV, women were rated lower. Mothers were rated lower on competence, commitment, the leeway they'd be given, how many days they would be allowed to be late before there was a penalty, the score required on an exam in order to get that job, and then the salary recommended was lower. Fewer women were recommended for management, fewer women were given high likelihood of advancement to promotion, and actually the overall proportion recommended for hire was lower. So what happened to the male applicants, you think, between the fathers and the people who didn't have that indicator of being a father? It's not neutral. It's actually the opposite. If you were a father, you were considered more committed. You were allowed more leeway to be late. You're like at home babysitting your kids or whatever. You had a higher recommended salary because you have a family to support. We should help you with that. More were recommended for management, higher likelihood of promotion one day, and a higher proportion recommended for hire. So I just want to point out, again, there are more subtle things than just gender. There are ways in which the roles that are differentially ascribed to women actually are an additional penalty. And it's not just that it's a penalty against them compared to men, it's that men are for the same work are given these higher valuations. And so I think these things all intersect in complex ways and sometimes make the valuation discrepancy bigger than we thought. So I'm about to move on to solutions, but I just wanted to see if anybody had a comment or a question at that point.
I have to say I'm a little bit depressed by this because you see that, like, for instance, you watch Mad Men and you see that and you're like, well, that was then, and we're still doing the same thing.
Yeah, I think it's so important to not stop there. I don't give hopeful data. I'm sorry. I actually was like a little bit more hopeful pre-pandemic. I think there's lots of ways the pandemic exacerbated all these things, including the way that domestic work played out. But I do end on solutions, and we'll end with your own solutions because I'm sure that people have found ways to be really productive. And I think there are positive ways out. I think, and I'll mention a few of them here and then we can just stop and talk. But I think one is to go back to what I talked about at the beginning, and just remember that diversity is imperative to our healthcare mission. Diversity, equity, inclusion are really imperative. And we cannot gain or sustain diversity without having the full thing: equity, inclusion, and belonging. Diversity is really just a checkbox. And I think, there was a time where I think the conversation was really dominated by the moral imperative to have better diversity. And I think it's shifting things to work done by, companies like McKinsey, Catalyst Research, and others. And what we see across industries, including healthcare, is that everything that we seek to do, from improving patient outcomes to being innovative, to having financial stability, to having good customer orientation, to having reduced employee turnover, everything is made better if our workforce, our boards, and our leadership are truly diverse. And I think, when I talk to companies, this is really the language that we tend to use, is that there's a whole host of things we want to do better, but really diversity is so positive for financial stability. It's not we succeed despite diversity, it's a necessary part of succeeding over time. I think we do really have to be mindful of the way the biases creep in the studies, like in the studies that I talked about. One easy thing just to do tomorrow, and I'm sure that you and I think most other medical institutions are really doing a lot of these things and are much more aware and explicit about these things. But, I think we're so aware of all the selection biases that come into place, and also aware that the previous ways that we tried to insert more diversity inclusion in our selection processes likely weren't effective. One of those is like this idea that that you needed to have at least one person from an underrepresented population in order to try to hire better. And then this is research that was published in the Harvard Business Review, where we see that the one and done in terms of your applicant pool can be pretty useless. So they looked at both racial diversity and gender and gender diversity in applicant selection, and they found that basically, if you do that if you insert one woman in a pool of applicants, or by the time you get to your finalist pool, if there's just one woman out of 4, say, the chances of that woman being hired is not 1 in 4. It's statistically 0, and the same if you have a racial minoritized candidate. And basically, it's not linear. Basically, if you just add at least 2 women in that finalist pool of 4, the chances are 79 times greater. And you're kind of wondering what 79 times 0 is, but I think the math, it's like some very close to 0 number, and then it's hugely boosted. And for minorities, it's 194 times greater if there were at least 2 minority candidates in the finalist pool. And they're calling this the status quo effect. And basically, you need to show that having a woman or a racial or ethnic minority is the norm. And you show that with your applicant pool. So the token one is likely to be ineffective. We need to really expand our idea of how we build our applicant pools and what we put in front of a selection committee and how we advance people to the final round. And there are so many biases that play into it. A huge one is pedigree or fit bias. I mean, when I see somebody who's from my alma mater, I'm so aware of how that floods me with all these, I have this dopamine reaction, and that bias really feeds the process. And we need to be really aware of those and check them. Anchoring and halo, looking at an application with a certain lens, so that we are inclined to see good things once we've seen certain characteristics, even though they're not written explicitly on the page. These confirmation biases, the affinity bias, conformity biases, there's kind of safeguards for all of them. And any selection committee needs to be talking about these, aware of these, and make sure they're employing practices and mind frames that guard against them. I think, a lot of it is out of our individual hands, and has to do with a shared vision and being really strategic about how we deploy our frameworks for health equity, diversity, equity, inclusion, and belonging. And I won't go over this in detail, but when I see a place without a plan, I feel really depressed, because everything that we do, I mean, when we want to be a stroke center of excellence, it's like we deploy all these things. There's clear frameworks of institutional change. We're so careful about the process. We data analyze it to death. I mean, if I send somebody to CT 3 minutes late, I know about it within the month, and I get some corrective actions. And yet we don't behave the same way when we fail to meet our benchmarks around equity or DEI goals. And I think we need to be just as rigorous as, theoretically grounded and as intentional as we move forward with these efforts, and use the same iterative processes for improvement when we fail to meet key benchmarks. And part of that is being strategic enough to have an actual timeline. This is a slide from the Oregon Clinic, which I gave a talk to that kind of led to this talk. And I love the way that they've laid things out so much that I now have stolen the slides. But everything that they wanted to do, every key activity that was mapped to an objective, and those were all laid out on timelines that they were very intentional about meeting. So I love to see something like this. It creates momentum. It puts everybody on the same page. It makes everybody understand where they came from and where they're headed. And I think it's so key to be explicit like this with timelines. I have a particular interest in leadership frameworks because I think none of these things can really happen unless we improve the way that we do leadership. So people sitting in leadership roles for like 47 years. I interviewed for a job once where a leader had been in place for 39 years, the role that I was applying to, and I thought, that has to be bad for an organization for so many reasons, but it also does not allow us to meet any DEI goals. So I think, we need to have specific goals, more horizontal leadership structures. So there's not just one person who we all depend on, an open application process for roles, especially roles with buy down, using some of these best practices for recruitment and selection. I'm a big fan of term limits, rotating roles, and clear succession plans. I think we need to talk a lot more about role segregation. How is it that we are non-verbally triaging people into subspecialties? We're clearly doing it within healthcare, and I think we need to explicitly end it to give people the same opportunities in practice, and then routinely assess, again, equity of leadership roles and how we're doing in diversification. And then, these are all things that if you give these talks, you hear them over and over again. I think every place kind of feels like, well, it's a problem, but we're above average, which I think that is so true for some places, but we can't statistically, I'm a researcher, like when everybody thinks they're above average, it's like, it hurts my math brain. I think it's tremendously hard to see our own privilege if we're not subjected to, to inequities. And I like maybe the gentleman who dropped in was one of those people, just sitting on the right side of the sign and you don't see the other side of the sign. This is from Dr. Camara Jones, who's a wonderful public health leader. There's Pandora's box. I think a lot of places are like, nothing has bubbled to the surface, so let's just not even open the lid. Very strong sense of zero-sum game, I think, from people who are in positions of power and privilege. If others gain, I lose. And again, because all of these efforts tend to elevate an organization, that doesn't need to be true. And then intent to impact, we all have great intentions. We saw that in 2020, and the translation to impact is something that is a lot harder and takes sustained effort and investment over time. And then I think also, you saw this a lot during the exigencies of the pandemic, but it always seems to be, we have to deal with the crisis in front of us, and all of this nice sounding work is in the future, and that makes equity and DEI work always in the future. And I think we have to just take the attitude of now is the right time, almost always. So I will stop there and just would love to get comments about what you think I missed, key solutions that you think have worked in your world, or any other observations about things that I've been talking about. Thank you. Oh, and just, I see the comment about medical AI, and I think that's super interesting because I spent a lot of time talking to people about digital innovations and health equity. And, AI, although we often, it's often a black box and we don't know how it works, it still depends on the data that is out there. And so I will see, I'll see papers, or I'll see, say, grant proposals where they talk about the way to eliminate, bias or inequities is to rely on AI rather than humans. And I totally understand why it might mitigate some biases and inequities. But ultimately, I mean, if you look at EHR, just like the way that we document about patients with, let's say, substance use disorders, or mental health problems, or racial and ethnic minoritized groups, we used biased language in that. And so, AI uses existing medical records to create, say, a templated note or to make assessments about populations. And it uses the bias data that we put in order to put out different data. So it's like, how do you decouple those things? It's impossible. So AI is not like, you know, it's not this quick and easy solution. I do think it can be a thoughtful aid.
Well, I think we have a small enough group here. You can go ahead and unmute yourself if you have any questions, or if you'd prefer, you can put them in the chat.
Silence is good too. It can be so meditative, you know? I'm curious about any innovations at GW or things that have worked well within people's departments or not worked well in terms of gender equity or general health equity.
Well, I know one of, oh, go ahead.
Oh, sorry. I had a question in regards to with your research where the minorities, was education a factor as well in some of those decisions? Because I know that being minority myself, I was always taught that it's very, very important to go to school, get that degree. It's kind of like drilled into your head. And then if you, especially if you want to take on healthcare, certain roles, like one of my goals would be to go into nursing. Sometimes that cost can be pretty great. And then you are met with the factor, as myself, being a woman with the lower pay and then expensive school and then other responsibilities, they're kind of just initially kind of placed on you, being the primary provider for children, the raiser, the upbringer, the trainer, teacher, and then you go to start, you know, trying to make your way forward. And how do you, I guess, bridge that gap where you want to do more and explore more, but it gets so expensive, and it just seems like there's like this brick wall and trying to climb over, like you're met with one financial obstacle after another.
Yeah. I mean, no easy answers. You're absolutely right. And we there's a lot of great, you know, Bureau of Labor statistics about how women, and especially women of color, just have less financial reserve, you know? And so it's like, then you get shocks periodically in life, you know, whether it's illness or caregiving roles or economic downturns or whatever. And women, and particularly women of color, are affected more because we had less financial reserve to begin with. And so I think the answers are in the workforce, and there are some hopeful things. You know, I think there are a lot of, for example, there's a lot of understanding that workforces need to recognize that they rely on women and they need to compete for the best talent. And so there was a study that was done right in the middle of the pandemic when we realized that we had a childcare crisis, you know, because all of a sudden when like children could not go to school if they had respiratory symptoms, we realized, oh, then whole companies cannot operate because who's home with the kids? Our women workers are home with the kids. And so there was, I was on a conference call where they presented data, and it said something like 98% of HR offices across corporate America were actively planning for better childcare supports for their employees. They had initiatives planned for the next year. So I think this whole like, just deal with it. We don't want to know about your private life attitude is just not working in today's economy, where we really have to occupy, you know, we really have to recruit and fill whole workforces that are depleted. I think we are now beginning to understand, we meaning, you know, companies that hire people are realizing that they cannot be ignorant to the fact that people have families at both ends of the age spectrum. They have loans, they have complex lives, and everybody who comes to work is a full human. So I'm hoping that some of those things where it feels like a choice between one thing or the other feels less so, particularly for women and for women of color moving forward. I won't pretend that it's going to be fixed overnight, but at least we are. I think there was this eye-opening aspect that was this teeny tiny silver lining of the pandemic.
Thank you. And just partly towards that second part, is there anything that you would recommend kind of bringing up in a conversation to make sure that this is kind of being like, I guess, accepted, or something that you see in your own department? I guess I'm talking about myself, maybe opening the lines of communication so that, because here, working in America, it's 40 hours a week, sometimes more. It's a lot of yourself that you're devoting to something. And especially like the pandemic, opened a lot of people's eyes, because there was that big hiring thing where people are just like, there's more to just the day-to-day. So I myself personally, when I was looking for work after the pandemic started to slow down a little bit, because I'm a parent, so I had children, so I couldn't work during that time. And then going back, I really kind of focused on making sure that whoever I work for is trying to open those doors for diversity and equality with women. So I just want to make sure that there's something, I can say to make sure that that line of communication is still being open for discussion.
Yeah, I feel like, it is so hard, and I would say unfortunate that often the burden of making sure that those efforts are there are on the people who are most affected, who often, also need to be protected against backlash. It's like the way I was raised and the way that I entered the workforce a long time ago was like, don't make any trouble, like just keep your head down and work and don't make any trouble. But, and obviously it's a lot easier to feel free talking about these things at this end of the spectrum where I've been working for a long time and I'm a full professor, and there's some like, there's a lot of job security that comes with being old, but at the beginning it is hard. And I think a lot of that conversation needs to happen with allies. I certainly think that everybody coming to jobs should ask things like, what are your policies for supporting people with families or people who have caregiving responsibilities? What do you do around family leave, around parental leave, and just like giving them a chance to shine. And when I interviewed at various jobs, you could just tell who was waiting for me to ask. They're like, boom, here's this thing, here's this person, here's 5 support groups and your affinity group. And like, you could just see them like shine. And they were happy. And there were other people who just like looked really uncomfortable and referred me to somebody in HR so they wouldn't have to talk about it. And like those things were so influential to me, hugely influential, because I have 4 kids, so it's not like I can just kind of make it happen without a support group. But I would say too, I think I think people who are early career also need to rely on those of us who feel a lot more comfortable speaking up. And I think finding mentorship, seeking mentorship. Hopefully those of us who are more senior are always reaching out and looking for opportunities to be that mentor. But I think it's a lot to put on early career people. And hopefully those of us who are more senior, can really stand up. And I've had a number of people who, when I'm sitting there in a room, are the ones who are like, why is Esther the only woman in this room? Or sort of be like, it's funny how, although I have a senior mentor who's a guy, but he'll say things like, it's very strange how everyone who's spoken for the past hour and a half has been like a white guy. He's like, is there anybody else we want to hear from? Because I feel like that would be, and I just think there have been so many people who are willing to like step up and be mentors and ask a lot of hard questions about, about how we treat people in the workforce and how we compensate and consider voices and leadership and opportunity, how we decide who goes forward for promotion or gets nominated for an award or who gets considered for, for a raise. And so I do think like kind of seeking and finding that mentorship and making it, making relationships that help you understand when you need to advocate for yourself, but also are the people who are going to be the true sponsors and actually speak up at times where it's difficult for you to do so. That is what needs to happen in every workplace. And so that's something to look forward to.
Thank you.
Of course.
Well, I think we are out of time. Thank you so much for that very thought-provoking presentation. And I think we all know there's a lot of work to be done here, and we're all trying to do our own little part. And you've definitely given us some solutions and some thoughts on how we can continue to do that. At GW, we do have some resources. For one that came to my mind, we were talking about this, the Anti-Racist Coalition, which is doing exactly the type of work you're talking about, that allyship. So hopefully we will see that needle moving on the data in the not too distant future.
I put references again in the chat, just in case anybody wants them. And if there's something you're looking for that I missed, please let me know, because I may have done some wild last minute edits of it. So I can always insert more.
Wonderful. Thank you so much. And thank you all for coming.
Thank you all for your time. Have a great day.
Bye.